Okay, hello everyone. Welcome to this presentation on ART in women. These are my disclosures. Okay, and the presentation is titled ART, which drugs are safe and what are the challenges. For the start, I'd like to turn it around a little bit and look at today's challenges first. So when we look at the issue of HIV prevention, we really have to find ways that reach women with testing strategies. So appropriate testing strategies for women is really a challenge. And I think we have to involve more gynecologists. And that is also true for PrEP. So pre-exposure prophylaxis is not well known by gynecologists. And so women who might benefit from PrEP miss information and miss starting PrEP. So when it comes to ART in women, we mainly look at young women or women of childbearing age, and we look at pregnant women. And what we might miss is there are a lot of other interesting periods in a lifespan of women. We have two periods of transition, for example. We have adolescence, adolescent women, not the same for men. Um, they really have problems with adherence, or they might have problems with adherence. So it's a really challenging life period. And we have more and more issues in our clinical practice with menopause. So as our cohorts and our women with HIV are aging, the issue of menopause comes up, and this transition through menopause is really new for the women and also for us as clinicians. And whenever we discuss issues or gender-specific issues, women-specific issues, we have to distinguish between sex and gender. Sex, biological factors that might influence something, um, genetic, genetic factors, and also gender issues like psychosocial issues or role models. And so we have to look carefully, distinguish, and sometimes it's both that's influencing a factor. Now today we keep to the mainstream and we look at ART in young women and pregnant women, and no doubt this is really important. First, let's have a quick look at this great story of success when it comes to treatment options and in people living with HIV. And these are the most important treatment options over time, starting from the first drug ACT license for treatment in the mid-80s. And now we have these antibodies available and long-acting drugs ahead. So it's really a great story. But the question is, do women with HIV benefit from new treatment options to the same extent as men? So to answer that, we can look at the percentage of women um, included in clinical trials. And here are so-called old data. They are not that old, actually, from 28 to 2014. So the percentage of women in randomized clinical trials from 10%, the lowest, to 31, I think, was in the Castle study, at the Zanavir study. And it was kind of embarrassing when Chloe Orkin showed new data, recent data, at the European AIDS conference in November last year. And she looked at some recent study, they are listed here on the right side, looking at 2 drugs and 3 drugs regimen. And overall, there was a number of 2,850 study participants, and only 421 of them were women. So this is a percentage of 15%. So when new drug studies of new drugs are presented, the last sentence always is like something, the study drugs were effective and generally well tolerated. And what should be added is in men. So when you ask investigators, why did you not include a higher number of women? The answer might be, we couldn't find enough women for our study. In our country, there are not so many women. Okay. If you look globally, half of the people living with HIV are female. In Europe, it's around 30%. It differs between the countries, with the lowest percentage in Germany and Spain and the highest in the UK and France. But I mean, even in Germany, with around 20% of women, and with a low number of 87,900 people living with HIV, it's still feasible to find, let's say, 50 or 100 women for an international trial. So there must be other reasons why there is such a small number. And indeed, there are possible barriers for women to take part in a study. First of all, pregnancy or or the potential pregnancy is a problem to participate in a trial. And there is always a safe contraception requested. And for new drugs, usually it's also IUD. And the costs for that will not be covered by the investigator. The woman herself has to pay it. Now, why should she do that? And also, if she had this close monitoring in a study, if she has to come to the clinic more often, the costs for the childcare or the costs for travel expenses is not reimbursed all the time. And overall, women living with HIV, they have a long list what they have to do. They have to take care of the family, they have to work, and the long list. At the end of the long list, there comes HIV infection of themselves. So they have lack of time and money. And when we design a trial, or when investigators think about a framework, they have to keep in mind the special challenges of women when they want to participate in a trial. And I think we could do more about that. So leave the trials. Now the drugs are licensed. What is recommended for women living with HIV? And when you look in the guidelines, if you look at DHHS or the European guidelines or in our national guidelines, when it comes to women-specific recommendations, it's more or less all about babies. So it's about pregnancy issues. And I think there must be a missed opportunity, because we have to keep in mind that the majority of pregnancies in women living with HIV, they are unplanned. And the younger the women, the higher the percentage of unplanned pregnancies. But unplanned does not mean unwanted. So the woman gets pregnant, it was not planned, but she wants to stay pregnant and give birth to the baby. So, and she might be on a regimen that's not recommended for pregnant women. So the best would be, up to me, to have the woman on an ART right away from the start, where she can get pregnant and you don't have to switch medication. Let's have a closer look at HIV and pregnancy. So what are the today's challenges? We still have missed opportunities, missed early testing in pregnancy. So based on that, a missed chance for early treatment. We have quite a problem with the close monitoring, because again, women have to travel, they might have other kids, they have to organize childcare. With migrants, we have lots of migrants living with HIV. In Germany, for example, communication is really a problem. Then we see some women late, so we don't have enough time to get the viral load fully suppressed till delivery. And if they really present late, it does not mean they have been tested late, but they present late for treatment. The whole pregnancy is like a black box. Sometimes you don't even know, was it a new infection during early pregnancy, or did the woman have other infections during the course of pregnancy? So we just don't know anything. So that is really a challenge. And then some women treated well, they show up with a viral rebound in late pregnancy. That can happen. And so also time is running out. We have to intensify ART, and it does not always work. And we have some women, they present during early pregnancy and they get lost to follow up. But the most interesting question for us at clinicians is, what is the best ART for this pregnant woman or for all pregnant women? Is there the one and only ART for pregnant women? Let's look at the guidelines that will tell us. So how do we treat pregnant women? And once again, maybe it's better to ask, how do we treat women of childbearing potential, so young women? So DHHS guidelines for pregnant women have been updated just in April this year, and they say the preferred nuke backbone is abacavir 3TC or tenofovir FTC or TDF 3TC in combination with either an integrase inhibitor, dolutegravir or raltegravir, or a PI, and two PIs are recommended, atazanavir and darunavir, both boosted with ritonavir, and of course in combination with a nuke backbone. The European guidelines have been updated the Congress last November in Basel, so they look pretty much the same. Also, two nukes in combination with an integrase inhibitor, also dolutegravir or raltegravir, or in combination with a ritonavir boosted PI. The European guidelines only recommend darunavir with ritonavir first place. So we also got warnings during the last 2 years. So be careful to use COBE boosted regimens because there is a risk of virologic failure due to insufficient drug levels in late pregnancy. So, and then we run out of time to get the viral load fully suppressed again, and we have a risk of vertical transmission then. Then we all followed the discussion on dolutegravir. Um, Lately, when it's used pre or peri-conceptional, there is still, looking even at the latest data, a small but increased risk of neural tube defects, NTDs. So these are the latest data from the TEPAMO trial in Botswana, published in April 2020. So in mothers who conceived on dolutegravir containing regimen, um, there were 7 NTDs out of 3,591 live births. So this is an NTD rate of 0.19%. Compared to mothers with other regimen, not containing dolutegravir, we see 21 NTDs out of 19,361 live births. This is a rate of 0.11%. And then looking at HIV negative mothers without treatment, of course, we see 87 NTDs out of 100,019 630. I think I messed up this number, but you can see it here, resulting in a rate of 0.07%. So what about all the other drugs? Not shown here in the recommendations or in the cover section. Are they safe in pregnancy? Well, remember, pregnant women are not included in randomized clinical trials for new drugs, so it takes time to find out. And the best way to find out is to look at the registries, the pregnancy registries. We have national ones, we have international ones, and the largest one for HIV drugs is the Antiretroviral Pregnancy Registry in the US. And twice a year, they show the new numbers, and we all look at this table, and you see the drugs listed on the left, and then you see the number of birth defects and the number of live birth, the related live birth. And you see some drugs are missing, doravirine, bictegravir, for example, because a drug is listed in this table when we have seen at least 200 drug exposition during the first trimester of pregnancy. So then the next column shows us the rate of malformations, birth defects, and you see on the right side two big non-HIV registries, US registries for pregnancies, so you can compare that rate to the average population. Let's leave pregnancy. What about contraception? There has always been a discussion on how can women living with HIV use oral contraceptives. So there might be interactions. So what can we recommend? Well, to sum up, it's getting easier. We see drug-drug interactions between hormonal contraceptives and also menopausal hormone therapy, by the way, um, between boosted regimens, mainly boosted PIs, and then with the old NNRTIs, with the integrase inhibitors, if they are not boosted, we don't see it. So it's getting more easy. And if we are not sure what to do, we can always look it up. There are excellent drug-drug interaction tables. For example, here is one address you can use, the Liverpool working group, and you always find what you are looking for. So it's really getting easy. So we can offer women enough choices for contraception today. So in summary, the percentage of women in clinical trials remains low, and we could easily change that, I think. And because of the fact that this percentage is so low, it takes time to get women-specific data um, after a new drug is licensed. It takes even longer to get pregnancy data on efficacy and safety. I think Chloe Orkin and Basel showed that it takes 6 to 8 years to get the PK data of pregnant women or breast milk. So especially, it takes really a long time. For women of childbearing age who consider pregnancy, there is a limit. There are limited treatment options. If you want to treat them right away with a regimen they can get pregnant with, but if you think how to switch a woman, for example, from a once daily to a twice daily regimen, also different classes to use, always keep in mind virologic response is the most important issue. So it does not make any sense to switch a woman and then have the risk of virologic failure, but you use drugs that are recommended for pregnancy. So always look at the single woman sitting in your room and get the best decision for her. So despite some possible drug-drug interactions, women living with HIV can use oral hormonal contraception. You only have to keep in mind boosted regimen are and older drugs might cause problems. And my personal outlook when it comes to HIV in women and treatment is optimistic because data on ART in women is increasing, as well as the number of female researchers. And I think that's a causal relationship. And I want to end with a statement. I think caring for women with HIV, looking at the different life stages and different challenges, it's really a great job. It's not a bit boring, and I hope my presentation also was not so boring. And thanks for your attention. And here's my email address if you want to contact me. Thank you.